Hello, welcome guys. I am Shariq Ahmed and I am currently pursuing MBBS from Madras Medical College, Chennai. So basically I had started this YouTube channel to share my knowledge with you guys. So for that I had chosen subject of pathology, because as you know, pathology forms a core subject which lays the foundation for understanding medicine, surgery, etc. So in pathology I will be dealing with the systemic pathology, because in general pathology, generally if you know that topics superficially, that's more than enough. But in systemic pathology you should have a good knowledge, and in-depth knowledge is required for understanding medicine, especially medicine, right? So pathology and medicine both are combined together, both are considered together, because in pathology you will read what is the definition of the particular disease and what is risk factors, pathophysiology and clinical features mostly. And in medicine, the treatment part, that is investigations and treatment, that will be discussed mostly in medicine. It will be useful for both second year students, especially second year students, and also for third year and my final year friends. It will be useful for understanding. So in systemic pathology, today we are going to deal our first topic, which is cardiac pathology. I will start with the cardiac pathology. It will be a series of discussion or a series of lectures, right? In this we will be discussing about we will be discussing about ischemic heart disease. So the name itself says the condition, ischemic. What is ischemia? Loss of blood supply. So the blood supply is reduced to the heart. That is the concept behind this. Or before going into the topic proper, we should have a good knowledge about what is ischemia, what is hypoxia and what is infarction. Now what is ischemia? Ischemia means loss of blood supply to a particular organ, right? And what is hypoxia? Hypoxia means oxygen supply is reduced. So in this you can say ischemia leads to hypoxia, but not vice versa. Okay, if something is occluding the blood vessel, then the blood flow to that particular organ will be restricted, right? And then what happens, the oxygen supply to the organ is also reduced. That's what it means. Okay, now what is infarction? Infarction, in one sentence if I want to say, it will be just cell death. My handwriting will be like this only because I am using this handmade stylus and I am writing it on Android phone, so little bit like this, so just try to adjust with me. Okay, so it's cell death. So basically cell death means it will occur, necrosis will occur. Now this ischemia and hypoxia together will lead to infarction. Okay, so there is some pathophysiology behind infarction which I will be dealing with now, because in future, in subsequent classes we will learn about myocardial infarction, right? In that also infarction will come, so you should know what is infarction. Let's get to the next slide. I will draw this. So what happens in a cell? First, the glucose will be obtained by the tissues, okay, and that glucose will be utilized by the cell in the form of glycolysis, right? Glycolysis. Now what happens in glycolysis? Glucose will undergo a certain steps and finally it will produce pyruvic acid. You know, this you will be reading in biochemistry. I am tying this pathology with biochemistry. Okay, now pyruvic acid is produced, and now this pyruvic acid will undergo oxidative decarboxylation, and what it will produce? It will produce acetyl CoA. Okay, it will produce acetyl CoA. Now this acetyl CoA will enter Krebs cycle. Okay, it will enter Krebs cycle, and throughout the Krebs cycle some amount of substrates will be produced, and along with that some amount of ATP will be generated. And what these ATPs are called as? These all ATPs will be produced, and these ATPs are actually called as substrate level phosphorylation. After this Krebs cycle, NADH, FADH, these all will be produced, and these things will undergo in the electron transport chain, right? Where it is located? It is actually located in the mitochondria. Now as this process goes, the sharing of electrons occur in the electron transport chain, and the final acceptor of this electron is actually oxygen. This is the main clinching point here. Oxygen is the main final acceptor of electron in the electron transport chain, and this reaction will take place and finally ATPs are produced. This is the mechanism by which cell produces energy, right? This is a biochemistry topic actually. So ATPs are produced and now these ATPs will be utilized as it is the energy currency of the cell. It will be utilized by the cells for its structural as well as functional integrity. So now what happens in infarction? In infarction, loss of blood supply occurs, ischemia, followed by hypoxia. Oxygen is not reached. So as oxygen is not going, as oxygen is not produced, what happens to the electron transport chain? As oxygen is the main component of the electron transport chain, which is the final acceptor of electrons, right? So it is not present now. So that whole electron transport chain will not occur. So this process will not occur, and what happens finally? The cells are not able to produce ATPs and the cell goes for ischemia as well as finally infarction, cell death. As cells are not able to produce energy initially, it will undergo reversible injury, right? Now I am tying this with general pathology. So initially it will undergo reversible injury, and followed by which, if timely intervention is not given, it will undergo irreversible injury. And after this, finally what happens is cell death occurs in the form of necrosis. So this is the point. First, initially, as the cells are not able to produce ATPs, it will undergo reversible injury. If timely intervention is not given, then it will undergo irreversible injury, and following which it will go to a state of cell death in the form of necrosis. Got it? So this is the mechanism behind infarction. Okay, so I had connected this pathology with biochemistry. You should know this point. We know what is glycolysis, everything. We know what is infarction. We have to just connect or collaborate each other, one subject with another subject, to gain proper understanding. Okay, so let's now go to our topic proper, that is ischemic heart disease. So first thing what you should know is, it's not a single disease. IHD is actually a group of syndromes. Okay, it's a group of syndromes. That means more than one disease is associated with this, which is related to myocardial ischemia. This we know. Okay, what is the cause? What is the important cause? That is atherosclerosis. Atherosclerosis is the main cause of IHD. We will deal with atherosclerosis when we will learn about the vascular chapter, right? So here you just know atherosclerosis, as you will be familiar with this atherosclerosis, right? There is, suppose this is a blood vessel, and the atherosclerotic plaque, that is the cholesterol plaque, will occlude this vessel and the blood will not be able to flow through this. Suppose this is the heart, this is our topic of interest, heart. As the blood is not able to flow through this lumen, it gets occluded, right? So this is the atherosclerosis, and this is the main cause of IHD. So what are all the risk factors of IHD? If I ask you, then indirectly that means what are the risk factors of atherosclerosis? Okay, so the risk factors of atherosclerosis are high LDL. One is the high LDL, that is the low density lipids, which is also called as bad cholesterol, and the other one is HDL. If the HDL, which is good cholesterol, if it is low, then it is also a risk factor. And after that, high BP, smoking, insulin resistance, diabetes. Actually this is diabetes, insulin resistance, weight gain. Obviously this all will form the metabolic syndrome. Okay, metabolic syndrome, MS, that is metabolic syndrome. And then lack of physical activity, old age. These are all the factors. Old age is one of the main component, right? It's a physiological component where atherosclerosis will occur automatically. So these are all the risk factors of actually atherosclerosis. So it forms the risk factors indirectly for IHD, that is ischemic heart disease also. Okay, so now what are the types of IHD? Actually, I said you before that IHD is a combination of syndromes. It's a group of syndromes. So it has 4 syndromes mainly. One is the angina, then the myocardial infarction, sudden cardiac death, and the chronic ischemic heart disease. Okay, so talking about the angina is divided into 3 types, that is stable angina, unstable angina, prinzmetal angina. And in this topic, in this lecture, we will be discussing only about stable angina. The unstable angina and the prinzmetal angina we will discuss in the next subsequent classes. Okay, and myocardial infarction, sudden cardiac death, chronic ischemic heart disease, as the classes progress, we will discuss that in the next lectures. Okay, in this topic we will focus mainly upon the stable angina. Got it? Now, what is angina pectoris? especially first year itself, you would be familiar that what is angina pectoris means chest pain. The one word which comes to our mind at seeing this angina pectoris is chest pain. But actually what the meaning is, angina is derived from the Latin word with anger, okay. This is just a anger, A-N-G-E-R-E, anger, okay. What that it means? Anger means strangulation, something to strangulate, that is the meaning of angina. And if we talk about the pectoris, pectoris means it is derived from the Latin word pectus, that means chest. So basically angina pectoris, if you combine together, that means something is strangulating the chest, okay, strangulating the chest. That's what it's given here, strangling pain in the chest or strangling feeling in the chest. That's the word of angina pectoris. Now what is stable angina? As I said you before, angina is divided into stable angina, unstable angina, as well as Prince metal angina. So now stable angina means it is something stable condition, like you can remember like that. So in stable angina, the patient will be normal when he is at rest. That's the point. When the patient is at rest, he will produce no symptoms. He will have no symptoms at all. But as soon as he starts exercising or some sort of emotional stress, like some sort of exercise or some sort of emotional stress he is experiencing, at that time chest pain will develop, okay. Chest pain develops on exertion. In one sentence, chest pain develops on exertion is the definition of stable angina. And what is the cause of this? Mainly it is also due to atherosclerosis of coronary artery, okay. So it's 70% stenosis is just a little bit controversial topic. So some say it's 65%, 70%, 75%. You can keep it in mind that 70% stenosis is like an average value. If the 75% stenosis of the blood vessel occurs due to atherosclerosis, then stable angina develops, okay. And it's a reversible condition. Remember, this is a reversible injury, it's not irreversible, okay. Next, now what is the pathophysiology? Why the patient on exertion gets this chest pain but not at the rest? I will tell you this, okay. First, initially what happens is, when the patient exercises, the muscles are in contraction as well as relaxation. The muscles go into a state of contraction and relaxation, and the metabolic demands of the body are increased, right? So this metabolic demand of the body, which is increased due to exercise, that should be met up by the blood supply. And so that what happens, the heart tries to pump more amount of blood so that this metabolic demand can be met. The heart should undergo tachycardia. The heart rate should get increased so that it can pump more amount of blood that can satisfy the demands of the body. And along with this tachycardia, that undergoes hypertrophy also, right? So that is increase in the cell size. Cell size increases. And remember one thing, that is hyperplasia will never occur in heart muscle, that is cardiac myocytes. Always only the hypertrophy is possible in this, okay. That is one more point of interest in general pathology, right? So hypertrophy occurs and tachycardia occurs, and now as hypertrophy occurs in the heart, the demand of the heart also increases, so it also requires more amount of blood supply. Now what happens? See, we'll draw a simple diagram now. Suppose this is the blood vessel and this is the heart, right? It has 4 chambers. Now there is hypertrophy of the left ventricles. Imagine this is a physiological hypertrophy which occurs during exercise, a little bit hypertrophy, okay. After that remodeling will occur and everything will become normal. So during exercise, severe exertion, some amount of hypertrophy will occur. The demand of the blood supply is increased at this portion. But as you know, in atherosclerosis, there is some atherosclerotic plaque which is actually occluding the blood vessel. As it is occluding here, the blood supply to the heart is limited. At rest, even though the atherosclerotic plaque is occluding the blood vessel, the blood supply which is reaching the heart is more than enough for that. But when the patient starts exercising, when hypertrophy occurs, then the demand of the oxygen, the demand of blood supply increases. But the blood flow is not increased at this situation. Why? The blood flow is restricted or limited because of the occlusion by this atherosclerosis. So the patient undergoes one state which is actually demand perfusion mismatch, okay. Then followed by that it leads to ischemia and the patient experiences chest pain, which is the classic clinical feature of that, okay. That is the pathophysiology behind the stable angina. Exercise, due to exercise the metabolic demands of the body are increased and as this increases, the heart needs to satisfy this demand, so it undergoes tachycardia as well as little hypertrophy, and to satisfy this to satisfy the cardiac myocytes, the blood flow has to increase, but it is not increasing as some atherosclerotic plaque is obstructing the blood vessels. So it undergoes ischemia, that is demand perfusion mismatch occurs and ischemia, followed by which the patient experiences chest pain. Got it? This is the pathophysiology behind the stable angina, why patient experiences pain only on exertion and not at the rest. Now let's go to the as I said you before, it's actually a reversible injury. Okay, if you give timely intervention at this stage, at stable angina, the patient will recover totally. Okay, there is reversible injury. And what are the clinical features here? Clinical feature is the chest pain. One is the chest pain. Obviously, it's a classical clinical feature of stable angina that is lasting less than 20 minutes. Actually, this is also a controversial point because some say it should not be more than 10 minutes. Chest pain should not be more than 10 minutes. Some say chest pain should not be more than 20 minutes or 30 minutes. I had taken it as an average, like what book you are reading, depending on that you can little bit modify this. Okay, I will not I cannot say you accurately that this is the 20 minutes is the cutoff for this, like that I cannot say. Okay. Then radiation, obviously radiation to the left arm, neck and jaw occurs, you know this point. And diaphoresis, why diaphoresis occurs and what is diaphoresis? There is actually the sweating, right? Sweating which occurs especially on the forehead. Any cardiac problem, mostly this will be the clinical feature which you will say in case presentation also, we will say the diaphoresis present or not, like that. Okay, and it occurs mostly due to sympathetic overactivity, that is one point. And shortness of breath. As the oxygen supply to the heart is reduced, the signal goes to the brain that see, I am not getting enough oxygen, I need more amount of oxygen. So what does the brain do? It cannot see that atherosclerosis is actually blocking the vessel, so it orders the lung to undergo hyperventilation, right? So the shortness of breath occurs, that's a symptom. Okay, so main symptom which you have to remember here is the chest pain. This is the only symptom which you should remember here. Going to this ECG finding, right? It's little bit investigation part, I will discuss this here only. So ECG, what we will see in ECG is ST segment depression. So before this, let me give you a basic. Okay, let's with my video, keep it here. What is okay, so what is this? This is actually a normal ECG. I am going to draw something, it will be like this, right? So this is actually the P wave, this is the Q wave, this is R, S, this is okay, ST. It's considered this as a normal, okay, normal ECG. PQRST, this is actually the atrial depolarization, and QRS complexes, there is a ventricular depolarization, and the T wave is ventricular repolarization. Okay, so now in this condition, stable angina, what happens is subendocardial ischemia occurs. What is this subendocardial ischemia? I will tell you, I will explain you in a little bit moment. Okay, just to remember, in ECG finding we will have something called the ST segment depression. So as you can see here, see, this is the P wave and this is the QRS complex. This is I am drawing, see, this is actually the QRS complex and this is actually the ST segment, right? This is the ST segment which is actually depressed. You can see here in this segment, the ST segment, it is actually straight. The isoelectric segment is straight, but here it is actually depressed. So this ST segment depression is the characteristic feature of subendocardial ischemia. Okay, now the question arises, what is subendocardial ischemia? So let me draw a diagram now. This is the blood vessel and this is the heart. Now heart is surrounded by 3 layers, right? So 3 layers of heart is present. One is the inside, which is this is endocardium, and the middle layer is myocardium, and the outermost layer is epicardium, and this full is surrounded by pericardial sac. Okay, this is the blood vessel. Now something occluding here, that is the atherosclerotic plaque is actually occluding here. So the blood flow is restricted, limited, right, and that leads to stable angina. Now what happens is the more vulnerable part of the heart is endocardium. Somewhere here initially this part, that is the subendocardium, that will undergo ischemia. Initially this part will undergo ischemia, then followed by this, if it is so severe, if that becomes so severe, then the myocardium as well as the epicardium will be involved. Okay, yeah. So here the diagram itself is there. See, can you see here? So this is the subendocardial MI. The MI, it's actually a myocardial infarction diagram which I had taken for this stable angina, but this is a stable angina, like this it will be. So this innermost layer is the endocardium, so subendocardial ischemia occurs. And now this is the transmural MI. If initially MI will present with a subendocardial ischemia, followed and after some time it will progress to transmural MI. Transmural means whole thickness of the heart will be involved. Now as whole thickness is involved, this is called transmural MI. You should remember here is the ECG finding of subendocardial MI will be ST segment depression. Okay, ST segment, it will be depression. And what will be the ECG finding of transmural MI? It will be ST segment elevation. That's the difference. If the ischemia involves transmurally, ST segment elevation will be seen in ECG, whereas in subendocardial ischemia, ST segment depression will occur. So that's why in this condition, if a subendocardial ischemia occurs due to stable angina, there will be ST segment depression. Got it? Now what is the treatment? This is the final slide actually. What is the treatment? Stable angina, it gets relieved by rest, right? So rest is a main option, that is the conservative management, plus nitroglycerin. You can give nitroglycerin, is a drug of choice, you can say, for stable angina. And just I will tie now this pathology with little bit pharmacology. Now how this nitroglycerin acts, that's the question. How this nitroglycerin acts? So nitroglycerin that generally goes into the body and gets converted into its active form, that is nitric oxide, right? Nitric oxide, and it's a free radical basically. So this nitric oxide, what it does is it will activate one enzyme, guanylate cyclase, GC, that is guanylate cyclase enzyme will be activated. And when this guanylate cyclase gets activated, it in turn activates the cyclic GMP, guanine monophosphate, cyclic GMP. This you will read in biochemistry. See here, again biochemistry came into effect. So guanylate cyclase will activate this cyclic GMP, and this cyclic GMP will relax the blood vessels. So the main action of this nitroglycerin will relax the blood vessels, so the burden, the load upon the heart will be decreased. As the load upon the heart is decreased, it will not undergo hypertrophy. Okay, it will not undergo hypertrophy. Hypertrophy gets reduced, and as the hypertrophy gets reduced, the demand of the heart, the blood supply demand of the heart gets reduced. So nitroglycerin is the drug of choice here. Topic gets concluded here. That is, we have seen stable angina mostly in depth. Mostly I had talked about the pathology from the perspective of pathology. I had told you about this. In medicine, some more points has to be added, like investigation part and the treatment part. We have to deal with it. Okay, so with this we conclude this session, our first session, that is stable angina, and in the next lecture we will see about unstable angina as well as Prince metal angina. We will discuss at that time. You can give feedbacks, comments, as well as criticisms are welcome, right? So that I can improve in the next modules. So with this I conclude. Thank you so much. See you in the next lecture.